Okay. Assalamu alaikum. I would like to thank Dr. Ali and Dr. Rashid and the other the chairman to invite me for this presentation. So my assignment today, it was just to talk a little bit about how to approach the management of sepsis in ICU. So when I thought what should I say today, I just attend the whole day yesterday and see what every people talk specifically about the fluid, about the pressures, about definition, recognition, and my assignment was to have it all together in 20 minutes. So let me just remind you that sepsis definition is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So there is 2 points in this definition. We have to have infection, and it's alone is just infection. How to change from infection to sepsis? There should be an organ dysfunction. Just remember the circulatory system. It's a pump, which is the heart. There is tubes. It need to have good vasoconstriction to maintain the blood pressure. And there is the fluid, which is the blood. So we have to have 3 components work together: good fluid, the pump, which is the heart, and the tubes. If you have a problem with any of these parts, you will have the hypotension or the shock state. For sepsis or septic shock, the problem mainly is in the tubes. So it's vasodilation, it's general vasodilation. That will cause the hypotension. There is relative hypovolemia and there is vasodilation. So if you have to treat the shock in septic shock patient, you have to give pressors and you have to give fluid. How much pressors and how much fluid? This is the big debate and the difficult question for everybody. Just remember, at the end, I don't need blood pressure to make the patient alive. I need a good microcirculation, the capillary bed. It has to be reperfused. The perfusion pressure should be okay or good enough to cause blood to go to the organs. So this capillary happen in every single organ, in the kidney, in the liver, in the spleen, in the lungs, the brain, every single organ. It has to have this capillary bed. If there is no perfusion in this capillary bed and there is good perfusion or good blood pressure in the major tubes, major arteries, you did not achieve the target of the resuscitation. So all of these markers, which is cardiac output, let's say mixed venous saturation, lactate, urine output, all of that is surrogate for the microcirculation. If you have a good microcirculation, SCVO2, it will be okay. If you have good microcirculation, lactate will be okay. If you have good microcirculation, kidney function will be okay, and urine output will be adequate. Let me show you this special technique to have imaging of the microcirculation. This is from the sublingual mucosa. They call it side stream dark field system. So just compare A and B. What do you think? Which patient is normal and which patient is having bad or no perfusion in the microcirculation? A or B? Okay, so A is a healthy person. So look at the microcirculation. Look at this vessel. Look at these small vessels. While in B, if you just look at it, there is no good perfusion. The microcirculation is already bad. So that's what will cause organ dysfunction. Again, look at A and B. Which one is the healthy and which one is the shocked patient? So A is healthy and B is shocked patient. This is the septic shock, cardiogenic shock, whatever shock. Hypotension caused dysregulation. This is microcirculation is already disturbed. So let me tell you the story about sepsis management. Before 2001, it used to be just arbitrary treatment. Everyone, maybe the senior physician, Dr. Ali can remember, the old day in the 90s used to treat patient without a standardized way. Every physician will have his clinical judgment. Tell Emmanuel Rivers, he came in 2001, he did this big trial or the landmark trial in ICU. I think everybody has to know it. What we call the early goal directed therapy. He set some specific goals for treatment in septic patient. You have to achieve it in 6 hours. And with that, he could achieve decrease in mortality from 60% to 40%. These goals was to have a good volume. He wanted to fill the tank, and his surrogate was the CVP. So you have to achieve CVP of 8 to 12. I think everybody remember this. Then you have to achieve a good blood pressure by achieving the good MAP. You have to have it more than 65. Other than that, you have to start pressors. And then look at the microcirculation, and his surrogate was the SCVO2, which is the mixed venous in the subclavian. You have to have it around 70. If it's less than 70, you have to look at the volume, either to give fluid or to give backed RBC, or even to give dibutamine as inotrope to support the heart. With this approach, this bundle, in 6 hours, he could achieve mortality less than 15%. It was 60, decreased to 40 or 38%. He did a revolution really in ICU. Over 18 years or 17 years, everybody was challenging him for the maybe after till 2013. Everybody challenging this bundle. We don't believe, they don't believe in all elements of this bundle. They don't believe that CVP per se will improve mortality. They don't believe that 65 is a golden number. They don't believe that SCVO2 was that important. So they introduced the lactate over the years, and they proved that lactate was superior to SCVO2. They proved that CVP is like a coin. It's nothing. You cannot depend on CVP alone to decide that fluid management is adequate or not adequate. So they try to introduce other parameters. And in 2000, let me continue the story. So with that, the Surviving Sepsis campaign was initiated in 2004. They adopt most of his elements, the CVP, the CVO2, the MAP. 2004, they repeated almost the same in 2008, almost the same in 2012. Then these 3 trials, everybody has to know the names: ARISE trial, Australian, PROCESS trial, which is American, and PROMISE, I think the UK, the English trial. So this is the reverse trial, which favor the early goal-directed therapy. When they repeat the process, the ARISE, the PROMISE, almost the same time, 2012, 2014, something like. And it was published almost the same time. So it proved that early goal-directed therapy is not superior to the usual care. They call it usual care. Just to mention that early goal-directed therapy did not harm any patient, but it was not beneficial. So you can use usual care, and this we have to define what is usual care and just repeat it. So let me just simply simplify the usual care. It was almost the same as early goal-directed therapy, but there is no CVP measurement, there is no SCVO2. This is the main issue about Edwards, about reverse. So with that, they proved that they decreased the mortality. Even sometimes 16% was in the Australian ARISE, 16%. Really, really good mortality decrease from 40 or 35 to 16%. So just to remind you that in reverse protocol, there was no mention about the early antibiotics. Nobody mentioned that. It's part of the protocol. But when we repeat this trial, 2014, 15, and 14, it was part of the usual care that you have to give antibiotics early. And that might cause the difference, and that what was really the key of improving patient in septic shock. When they have all the pooled analysis, they did it all for these 3 trials together, all patients. There is no difference between usual care and early goal-directed therapy. Doesn't mean that you don't have to do early goal-directed therapy. So the only element from early goal-directed therapy that survived, and we have to use it every day, it's early. The word of early. Whatever is good, you have to do it early. CVP, we don't use it anymore. SCVO2, we have other surrogate better than that, but anything you have to do it early. Antibiotic, early. Fluid, early. So Surviving Sepsis campaign 2016, they changed the guideline a little bit, so they don't use CVP anymore. They use other parameter, but in general, they emphasize on the early treatment. Whatever you want to do, you have to do it early. Just let me show you this retrospective analysis of huge amount of patients. I think around 50,000 patients. They compare all element of treatment. So when you apply 3 hours bundle completed early, so that will improve survival. This is the one. And broad-spectrum antibiotic to be given early also will improve survival. But the fluid management, it did not in this analysis. So this is the 3 hours bundle. It improved mortality, decreased mortality. The antibiotics decreased mortality, but the fluid management, it was not like significant. Again, this is for the antibiotics. So every delay, this is the 1 hour. If you give antibiotic in the first hour, mortality will be around 25%. If you increase it to more than 6 hours, the mortality will jump up to 34%, 32-34%. So every 1 hour delay, it will increase mortality if you did not give the right antibiotic. Again, this slide I think have been posted maybe 3-4 presentation by maybe Dr. Ali started with that. This is just a new update about the Surviving Sepsis campaign 2018. They need to have the bundle in the first hour. Even they did not. They were allowing 3 hours, 6 hours. Now it should be in the first hour. So you have to measure lactate level. You have to obtain blood pressure before antibiotics. You have to administer broad-spectrum antibiotics. You have to give the rapid bolus of 30 ml per kg of liquid steroids. This is 30 ml per kg. It's for somebody who is 70 kg or 80 kg. It's around 2 liters, 2.5 liters. You have to initiate it early. This is just discussed yesterday with Dr. Ali. So is it you have to finish that resuscitation in 1 hour? It's not necessary, but you have to start in first hour. And you have to start the pressors as well, and to keep more than 65. Usually, if I have a patient whose systolic is 80, he's awake, he's doing fine, but he's still hypotensive, I might start to press fluid and wait a little bit for the pressors. But for somebody whose PP is 60, I will not wait for the bolus to finish. I will start the pressors. And if it's pure hypovolemia, I can wean it in a few hours. Many times we start the pressor at the same time, even sometimes before the fluids. So reach 30 mic, which is really high dose. I give the bolus, first bolus, second bolus. In a few hours, the patient he's on 5-10 mics of levofed. So it's not a bad practice, and now it's even recommended to start the pressors with the fluid management. Don't keep the patient hypovolemic or hypotensive for a long time. The more time with hypotension, the more time with microcirculation disruption, and the high possibility of organ dysfunction. So just let me tell you, with this new guideline or new recommendation, they want to finish everything in 1 hour. There is around 870 physicians, they want to retract this guideline. They are against that. Their point is not that they are not against the whole guideline. They are against the time issue. Cannot be in 1 hour. They understand that you have to finish everything in 1 hour. They are afraid of the medical legal issue. If you did not finish everything in 1 hour, okay, you'll be sued in the court. That's their point. They think if you rush too much, you might have the wrong decision in the antibiotic. You might give the fluid to the wrong patient. He's not septic. You just give him fluid. That's their rationale. But anyway, they need 10,000 signatures, so it's too late. It will take too long time, and most likely they will not achieve it. Anyway, what's the best management for 3 hours bundle or 6 hour bundle or 1 hour bundle? I think the right care should be done right now. So you have to do the right care, and it should be as soon as possible. It should be right, and it should be as soon as possible. So let me have this clinical scenario with you and see how can we proceed with the management. We have Miss Jones. She's 65 years old female. She's presenting to ER with a 3 days history of chills and dysuria. She's having history of hypertension, treated with amlodipine. On arrival to ER, she reports feeling dizzy. Her vitals, temperature 38.6, heart rate is 110, respiratory rate is 28, saturation is 94 of room air, and her PP is 85 over 40, her MAP is 55. Physical exam showed dry mucous membranes, suprapubic region tenderness. This is usual patient, we see it every day in ER. So how to deal with this patient? Let me start with the recognition. It should be early. Adequate hemodynamic support of patient in shock is crucial to prevent worsening organ dysfunction and failure. So it's real emergency. I should not wait a few hours till I start the first pressor. I should not wait maybe 6 hours to give the antibiotics. It's real emergency. That's why they emphasize on the 1 hour bundle. You have to do everything in the first hour. At least initiated. Resuscitation should be started even while the investigation of the cause is ongoing. So hypotensive patient, don't think what the cause. All kind of shock, septic shock, cardiogenic shock, PE, the obstructive shock, hypovolemic shock, all shock need fluid. Maybe the amount will be different between shocks, but anyway, you have to start the bolus first 500. Even with the worst cardiogenic shock, you have to give some fluid, at least 500. So give the first 500, and while the bolus ongoing, think what's the cause. Do not wait too much till we figure out what's the cause. So you have to start the treatment before even the investigation and even the cause is obvious. Fluid therapy to improve microvascular. Just remember this word, the microvascular blood flow and increased cardiac output is essential part of the treatment of any form of shock. So the early recognition, the Q SOFA, the quick SOFA, 3 elements, very easy to apply for any patient. No need for that much of training, no need for calculation. So the SOFA score is really difficult. It has a lot of elements. We use the calculator to calculate it. So for the Q SOFA, it's just 3 elements. Glasgow Coma scale less than 815. Anybody can assess that. Respiratory rate more than 20. You need just watch to calculate the rate. And systolic pressure less than 100 millimeter of mercury, just measure the blood pressure. So 2 out of 3, you have to think about sepsis and initiate the treatment. When they come, they validate this Q SOFA score. If you have 2 elements out of 3, you have at least 7% chance to have a bad outcome. If you have all the 3 together, it's around 23. So at least 2, it's a good chance to have a bad outcome. I mean sepsis or whatever. So this patient is having high probability of sepsis, septic shock. It might be UTI. I think everybody agrees with me on that. What should we start? I have to insert IV line. This is for sure. We have to take blood sample, initiate IV bolus. I just told the nurse, have an IV line, start 500, take a sample. Even I did not mention the sample for what. So what type of fluid? I'll start with the crystalloids. Normal saline is a good start. I will go with 1000 ml. She's on room air. So I should not be afraid of hypoxemia. I will send CBC for her, renal function test, the VPG should be done, lactate level, urine analysis, blood and urine culture and sensitivity and culture, and to order EKG. I don't like surprises. Sepsis can cause a lot of cardiac dysfunction and chest X-ray. Anyway, I did not diagnose sepsis yet. I'm just thinking it might be sepsis. This will be done for every patient, and it might change the diagnosis even. I have to start the antibiotics. I already sent the culture. How to know what the right antibiotic, either to remember it if you are the expert in the ID, or just check the Sanford. So I check the Sanford for this patient. It's complicated UTI. I will go with the tazocine. I will not go with the ceftriaxone. So the most common mistake in ER really, ceftriaxone for every patient in sepsis, which is really wrong decision. Don't go with the ceftriaxone really. If you want to go not some cephalosporin, cefepime may be the alternative as per Sanford. Cefepime is okay. But tazocine for such patient, I go with the tazocine. Diabetic, hypotensive, complicated UTI. So again, this is from the guideline. I hope everybody just download it and read it. Really, it's a good source of information. And if you just read it and masterize it, you are in a good situation. So you have to, it's a medical emergency, give 30 ml per kg, which is around 2.5 liter to 2 to 2.5 liter. IV crystalloid is a good start. They used to say 3 hours, now it's 1 hour. This, I think Dr. Osama yesterday already have this slide. Even if you are afraid of hypoxemia, patient with acute lung injury, with high flow oxygen, think about intubation. So it's not a reason to prevent fluid bolus. If your patient on high oxygen, he's already on oxygen therapy, he's maybe on BiPAP. If he need intubation, go with the tube. Don't prevent him from fluid. In end-stage renal patient or hemodialysis, congestive heart failure, you can give 30 ml per kg, but I never used to order 2 liter bolus. I never said 2 liter bolus. I am the physician. I'm working in ER. This is not an office. So I'll go to the patient, assess him, write order 500, and go with that. Then I'll assess the patient, other 500, assess the patient, other 500. So you have to frequently check on the patient, check on his awakeness, is he improving, the blood pressure, everything. And is he developing side effect like pulmonary edema? So the patient received 1 liter of normal saline. She's still hypotensive. Chest is still clear. Started on second bolus, 1,000 of normal saline. I repeated the other normal saline given, and her MAP is still 55. Now lab came out. Creatinine is 157. Usual normal upper limit in our lab is 88. This is millimole. BUN is 27. Normal is 20. I think 20. Lactate is 5. And by definition, more than 2 is hypoperfusion, is sepsis. And lactate 5 alone without hypotension is indication for bolus. Again, I'm not just looking about the blood pressure. I need the microcirculation, which is good surrogate for the microcirculation, the lactate. Albumin is 18. I just mentioned that for some reason. WBC is 20,000. Hemoglobin is 8. Urine analysis is positive for leukocyte esterase. And more than 100 white cell per high power field. Abundant bacteria.
Just
okay.
You have just 1 minute, please, sir.
I started late. So X-ray is normal level. She is in sepsis due to UTI. Should we give more fluid for the patient or start pressors? As we mentioned, we have to start pressors early. How to assess volume status? This is really difficult question. I will come through it. Should I target MAP of 55? As a start, yes, I have to target 55. Then I have to assess the perfusion. Look at the perfusion. The patient urine output improved, awakeness more awake, and lactate is coming down. 55 is a good perfusion pressure. Otherwise, I might go with the higher. So sometimes the patient on levofed 15 mic, I look at the MAP is 75 now. Urine output start to improve, so I might tell the nurse, keep it in the higher side for a while. I will assess in few hours, is it 75, is it 70, 55? Sometimes if the patient on low dose levofed and he's well perfused, I might stop it and keep the MAP around 60 or 55 if he's well perfused. So I have to check if this is good blood pressure or MAP for this patient. 65 is a good start, but this is not the final target. So how to assess to give more fluid? Physical exam might help me. Dynamic parameters like blood systolic pressure variation, lactate level, perfusion status, Glasgow Coma scale is improving, urine output, the SCVO2 and CVP. I have to look all these parameters together and have a decision. Don't look at just one parameter. Does not help. Again, microcirculation will be better with 65 to 70 for most of the patient. And again, you have to assess by the mental status, the skin appearance, the urine output. Too much fluid. Why should not I give too much 5 liters for the patient? Because too much fluid increases mortality. I have to give the right amount. Fluid is a medication. There is a dose for that. Hypoperfusion is a bad, and overzealous treatment is also bad. So patients start on levofed via peripheral line. I don't have central line now with 5 mic per minute, which is low dose. Then I give more bolus. LR now 500. I give it. Why LR? Because the chloride is a little bit high. So I give bolus of normal saline. I don't like to give 5 liters of normal saline. So I start to give less hypochloremic fluids. Central line was inserted. Levofed moved to the central line. It reached 25 mic per minute, which is really good dose. MAP is around 65. Patient started to have respiratory distress. She was intubated and started mechanical ventilation. Admit to ICU and A line inserted. So look at the A line wave. Just look at it. So it's up and down, up and down. So it's not like. So just give me 1 minute. I finish. So it's not a good wave. It's not like it's not a good wave. That means there's hypoperfusion. I mean hypovolemia. Sorry, hypovolemia. And the patient, if he given fluid, he will respond. After bolus of fluid, this is the A line wave. This is a nice A line wave. I like it for every patient. Again, this is the hypovolemia, and this is the euvolemia status. The pulse pressure variation. This is the good parameter. Albumin, I will go with albumin because the albumin is less than 30 and the patient is sepsis. Steroid, Dr. Energis will have light on it. Mechanical ventilation, I don't think we have time for that. And again, the last slide. So the fluid challenge, regardless of the test used, there will be remain a gray zone in which it's difficult to predict the patient response to intravenous fluid. So you don't know, even in the base parameter you use it, you don't know if it's right or wrong. But better than use 50% chance to have a good decision. It might be 80%, 90%. You are right in your decision. Fluid challenge technique is a good technique. You might go with the 5 poles. You don't know if it will work or not. You go with 250 sometimes, 500, and see if it's good challenge or not. Again, we mentioned the objective fluid challenge, improving systolic pressure, heart rate decreasing, urine output improving, lactate decreasing, SpVO2 improving. It was 50, now it's 70. Pulse pressure variation improving. And thank you very much.
Thank you.
Yeah, I said septic shock. I said shock. Sorry, so if it's in shock, yeah, you are right. If it's in shock and albumin is less than 30, you might go with the albumin. Thank you very much.
Thank you. Thank you.